All right, I do see that it is 3:30 p.m. Eastern, so let's go ahead and get started with today's event. Hello, everyone. Once again, thank you so much for joining us for the HAI Learning and Action Network Discovery event. My name is O'Neil Delvin. I'm with the NCC. I'll serve as your technical host as well as assist with monitoring the chat window during today's session. In a moment, I'm going to turn over to Beverly Whitted, who will assist us with today's discussion as well as our presenters that we have lined up. But before we officially get started, just want to go over a couple housekeeping items, starting with all lines are muted during this call. It's muted upon entry to help ensure that, once again, we help with minimizing any background noise that may come through. So you'll hear the presenters, but we do encourage that you get involved during today's event and ask us questions during the session. Please do not wait until the end. You can send it in as we go along. You will do that by using the chat feature. Now, the chat feature, for you to access it, I'll go over that in a moment, but basically at the top of your screen, you see the little green bar displayed. You'll be able to mouse over that to then access the chat window. As well as today's event is being recorded for internal note-keeping purposes, as well as to be made available via the NCC website. An announcement will go out to the community, letting you know when that information is available. The recording, in addition to the materials that viewed, so a PDF copy of the slides will be made available at that time. Also, at the end of today's event, there is a post-event survey that will display that we do ask that you please provide some feedback as it relates to today's session. Just another reminder, which you can see on screen as it relates to how you can communicate with us today. We do ask that you send your messages and via the chat window by sending it to all panelists. Okay, if you mouse over the little green bar that's displayed at the top of your screen, you will click on what looks like a cartoon talk bubble to access the chat panel, the chat window. And at the bottom, it asks, who do you want to send it to? We do ask that you select all panelists so that everyone who's on as a panelist can see the information as it, as you send them in. Also, if you want to get it to be full screen, which it currently is, you have the ability to click the little arrows to get it to be full screen, or if you want to take it off of full screen mode, you can actually just hit the escape key on your keyboard, and that will take it off of the full screen mode. With that, I will actually turn it over to Beverly Whitted, who will assist us with our introductions. Beverly? Bev, your line may be muted. Let me go ahead and just click the unmute button for you then to make sure that we can get you unmuted. Beverly, I'll turn over to you.
Well, thank you, O'Neil. And again, welcome, everyone. Thank you so much for joining today. And for those of you who were not able to attend our inaugural Discovery event in August, these sessions are planned and guided, as O'Neil said, by ESRD NCC, the National Coordinating Center, and the HAI LAN work group. And also, we're guided by our CMS subject matter expert, Lisa Reed. And as he also said, the event presentations and resources are housed on the HAI LAN portion of the NCC website post-event. And we're always interested in new voices and members for our work group. My contact information will be available at the end of the webinar, and this is a low-time and high-impact commitment. So please feel free to join us in our efforts to educate and eradicate HAI infections. And at this time, I would like to introduce Karen Strott, our speaker today, who will present an overview of the Infection Control and Assessment Response Program, or ICAR. And ICAR is a program made possible by the CDC, and it focuses on assessment of infection control and response practices in nursing homes, hospitals, and, of course, outpatient dialysis facilities. Participating facilities receive constructive feedback to improve infection control and response practices in their facilities. And Karen, as you can see, is an RN. She's also a BSN and has been a nephrology nurse for over 25 years. She has experience working at home dialysis, in-center and acute settings, as well as transplants. She may be familiar to some of you as she worked for 15 years as the Quality Improvement Director for ESRD Network 15 in Colorado. Since 2015, she has been employed in the Disease Control Branch at the Colorado Department of Public Health and Environment, and she specializes in dialysis infection prevention. Her current duties include visiting Colorado dialysis facilities to perform infection control assessments. These visits, again, aim to provide education and resources to staff members that will help them become aware of current prevention recommendations to reduce infections and identify areas that might be placing patients at risk for infection. Karen, you have the floor.
Thanks, Beth. Hello, everybody. I'm, again, Karen Strott, the dialysis infection preventionist from the Colorado Department of Public Health and Environment, and I'm going to be talking a little bit about the state of Colorado's dialysis ICAR program, what it is, how facilities are selected, what the process is for the site visit once the appointment is made, and finally review some of our preliminary findings from the site visits. So as you listen to the presentation, please remember that this is a Colorado process, and it might not be the same for all of the other states that are doing the ICAR visits. So O'Neill, next. Next slide. So before we get started talking about the ICAR assessment, I want to briefly go over some of the resources that are available to dialysis centers to help them reduce bloodstream infections in the dialysis population. And many of you might be familiar with the evidence-based core interventions the CDC has developed for dialysis facilities. These have been out for a while, and they've been posted on the CDC website. And these are recommendations that should be considered best practices for infection prevention in the dialysis population. So just in brief, the recommendations include performing active surveillance for bloodstream infections and other dialysis events and entering that information into the CDC surveillance system. And whether facilities are aware of this or not, someone at your facility is entering information on positive blood cultures, IV antibiotic starts, pus, redness, swelling that your patients may be having at your facility. So sometimes that's done by a centralized corporate person. At other times, you guys are doing it yourself. So that's a requirement for some of the states that are doing the ICAR assessments, as well as CMS requirements and CDC requirements. So the next recommendation is that you share the information from the NHSN surveillance with your frontline staff so that they're aware of what your bloodstream infection rates are and if you're having any problems with infections. So they also recommend that facilities do monthly audits of things like hand hygiene, connections and disconnections to AV fistulas and grafts, connections, disconnections to CVCs, and the like. So they have a catheter bundle that they recommend for dialysis patients, and included in that sort of bundle is reducing catheters, because we know infection rates are lower in facilities that have fewer catheters. They also recommend using an alcohol-based chlorhexidine solution greater than 0.5% as the preferred skin antiseptic for central line insertion and during dressing changes, and they have some alternatives listed for that. They also recommend applying triple antibiotic ointment or povidone iodine ointment to catheter exit sites during dressing changes. And alternatives to using the ointment would be using a CHG impregnated sponge or gel dressing. And most of you probably have heard about this, scrubbing the hubs of the catheters each time the catheter is accessed or disconnected. So that is also a recommendation. They recommend that you provide standardized patient education that's related to vascular access care, hand hygiene, recognizing signs of infection, teaching them how to care for their accesses when they're away from the dialysis unit, and risks related to CVC use. And last but not least, they recommend some topic areas that should be covered in staff education programs and continuing assessment of staff members to make sure they're using aseptic technique and providing the correct access care to patients. So all of the infection prevention tools, including the guidelines and audit forms and checklists, are on the CDC website, which is cdc.gov/dialysis, and it's all publicly accessible. So, and it's free, so I would recommend that you go there and take a look if you haven't already. And the last bullet point has to do with the Making Dialysis Safer for Patients Coalition, which is a new group that's gotten together and is going to be working on further prevention efforts for dialysis patients. So next. So moving on to the ICAR program. ICAR stands for Infection Control Assessment Response. It looks like some people have a little bit different acronym, and they're using readiness, so I'm not sure which one is correct right now, but we've always called it the Infection Control Assessment Response Program. These are assessments to determine if the components necessary for an effective infection prevention program are in place at facilities. And as Beth said, they're kind of a snapshot of how facilities are doing with the implementation of the core recommendations. And they're not just being done in dialysis facilities. They're also taking place in long-term care facilities, ambulatory surgical centers, and acute care hospitals. So for dialysis, there's a 19-page assessment that's completed for the chosen ones in the dialysis community. On the right is a snapshot. Oh, I just lost my slides, O'Neill. On the right is a snapshot of the respiratory hygiene section of the dialysis tool. And some of the areas that are looked at for you guys are infection control training and infrastructure, auditing of aseptic technique, immunizations, bloodborne pathogen exposure programs, the surveillance piece. Do facilities know how to report a reportable disease condition to the health departments? Are they donning and doffing PPE correctly? Are folks following recommendations for respiratory hygiene and cough etiquette? So it looks at a little bit different areas that focus more on preventing the spread of different types of infections that dialysis facilities are not kind of used to looking at. So to complete the assessment, we also do in-person site visits to observe the actual dialysis processes as they're taking place. And we use the CDC audit tools that are posted on the website during the visit so that we can look at things like put-ons and takeoffs for dialysis, medication preparation and administration, the CVC dressing changes, station cleaning, and hand hygiene. And after the visits, our facilities receive a report that has the results of the assessments and suggestions for reducing the risks that might lead to infections in your patients. So the report also contains a page that has resources on it that can be used for quality improvement initiatives. So it's not a health facility licensing survey. We aren't really looking at whether facilities are following the regulations and the conditions for coverage. The ICAR program at CDPHE is part of the disease prevention branch of the health department. So we're looking more specifically at the disease prevention efforts that are going on at a facility that help limit the spread of infections. So we're looking for gaps that can be corrected before they become a problem for patients at a facility. So next slide. So how do facilities get the golden ticket to receive an ICAR visit in Colorado? And Colorado has a risk assessment tool that was developed by one of our state epidemiologists that helps prioritize the site visit. So some areas that we look at are included on the slide. We're looking at the census of a dialysis facility. So people with higher numbers of patients are getting a higher priority. We look at bloodstream infection rates, access-related bloodstream infection rates, CVC rates, how long it's been since the last licensing survey, time elapsed since the last prevention visit for me. We look at VTAGs that are related to infections and the dialysis facility compare score and the star ratings, and also the percent of patients that are positive for hepatitis C virus. So the higher the score, the higher the priority to do a site visit. And what we do is that they have a composite score that they compute, and the facilities that have the higher scores are the ones that get the phone call or the email from me. So next slide, please. So the Colorado ICAR process, after the facilities are identified, if you're a chosen facility, you'll receive an email or a phone call from us, and there may be a pre-visit conference call if people have a lot of questions, or if they want to complete part of the assessment on a conference call. And folks would get an advanced copy of the ICAR assessment so that they can kind of follow along as we're talking on the phone. And then we set up the site visit, and usually I arrive pretty early at the facility, and someone gives me a tour. We look at the lobby area, the med prep area, lab area, looking at clean versus dirty areas and kind of how the stations are set up. Might need to look at some facility documents, infection audits or protocols. Sometimes people ask me to look at the storage areas. We usually do not look at water room or biomed areas, and that's more specific to Colorado. We don't need to look at the reuse area here because we only have one facility that is doing reuse in our state. So that area is probably something that's looked at in other states. So again, areas that are audited include medication preparation, the CVC dressing changes, the put-ons and take-offs, station cleaning, and hand hygiene. And then usually the day is taken up with that and talking with patients and staff members. There's usually an exit conference, and then the summary report is emailed later and it usually contains the things that we talk about in the exit conference, so there aren't any surprises. And after that, the information gets blinded and uploaded to CDC, and CDPHE also takes a look at it to help focus on infection prevention efforts. Next slide. So some of the things that Colorado is doing especially well with are cannulation and decannulation of vascular accesses. The steps are performed correctly in 94 to 100% of cases, with the exception of the antiseptic application and patient hand hygiene, which we'll talk about in a minute. And we do well with medication administration and preparation. 92 to 100% of the preparation steps are completed correctly, and 90 to 100% of the administration steps are completed correctly. We occasionally are forgetting to wipe down the septum of the vials when the caps are removed on new vials, and have to have a reminder to use new syringes and needles each time a multi-dose vial is punctured. Sometimes people try and reuse those. CDC, just as a side point, recommends that if multi-dose vials are used, that they're dedicated for use by a single patient. So we need to be thinking of how to implement that recommendation in dialysis facilities. Most facilities that are visited are kind of trying to move away from using multi-dose vials if they can. So I would be thinking about that. And also a reminder to keep multi-dose vials like heparin in an area that's dedicated for medication preparation is safer for patients if they're not out on the supply carts that are close to patient stations and where anybody has unlimited access to that. So generally in Colorado, we're also doing really well with our hand hygiene. People are using hand gel hundreds of times during the day, and they're doing it at times when they're supposed to. So that's a good thing. So next slide, please. So areas where Colorado isn't getting the best grades are patient involvement in infection prevention. You can see that patients are washing their access and hands pre-dialysis 67% of the time. So the soap and water is actually important because it removes certain pathogens more effectively than the alcohol gel. So they need to be washing accesses and hands pre-treatment. Patients using gloves to perform hand hygiene post-treatment 79% of the time. And performing hand hygiene post-treatment is done only 79% of the time. So that's an area that we can improve in especially having patients wash their hands before they leave the unit and before touching the door handle when they're leaving to prevent infection in other patients. So the implementation of the CVC recommendations is an area that we can improve in also. You can see that we haven't implemented that antimicrobial ointment application at the CVC exit site. That's being done only 8% of the time. And applying antiseptic correctly, the area that we need to improve in that is the contact time and the drying time, and applying the antiseptic according to the manufacturer's directions for use. We're pretty much performing scrub the hub correctly now. At the beginning of the ICAR assessments, most facilities scrub the connection, not the hubs of the catheter. So scrubbing the hub means that the cap is off and the hub is scrubbed before connecting to blood lines or syringes or vacutainers. And if the hub becomes contaminated, the scrub gets done again. So we're doing better in that area. But what's happening now is that most facilities have protocols in place, and most facilities have variation in practice. So pretty much probably half of the staff in facilities are doing the scrub the hub procedure a little bit differently, and it's not always according to the corporation's policies or the CDC recommendations. So we could do better in that area too. And then the last section is the area I think we can make the most improvement in, and that's environmental hygiene. And this is kind of an interesting one to observe. We have 39% of the stations are empty before the station cleaning begins, and CDC recommends that the patient be away from the station before you start cleaning the machine and the chair. So the patient should have left the station to prevent cross-contamination and also irritation or fumes being exposed to your patients. So we can do better in that area. 66% of the time, facility staff are disinfecting all surfaces of machines and prime buckets and things that are in the station. So it's kind of facility dependent what gets missed. Some facilities, every staff member is missing cleaning the left side of the machine. Other people have all of the staff members missing the inside of the prime bucket. So it's kind of facility dependent. And it's an area that I think we need to work on. So that kind of concludes my formal presentation